Hello and welcome. In this lecture, we're going to be talking about theories of change. Now, the reason we're doing this is that from the get-go, as you're thinking about a project, you want to be able to think about how you would describe to others what your ideas are about how you get from point A to point B. So if you're going to ask people to sign on to your project to help out with you, you're going to have to explain to them why they reasonably should think that if they do these things that you're asking them to do, they're going to actually get the outcome that we're all hoping to get, right? Now, when you think about theories, very often we think of them as being fairly abstract. But they're there for a very good reason. When we do different types of projects, interventions, we have certain things that we do, are essentially our inputs, and then we have the things that come out of an intervention, our outputs. Now, sometimes you do an intervention and it just happens to work, right? And other times it completely fails, right? So how do we understand why one program works and another program fails? Well, that's where theory comes in, right? If you have a theory where you have a certain understanding of how different components come together, you can actually begin to piece apart and determine or assess what makes programs work and what makes them fail, all right? So this theory is a structure with which you can have a systematic approach to assessing those things. Now, what we know is that programs that actually use theories, that use these structured approaches to thinking about things, actually tend to do much better in terms of achieving their outcomes that they're seeking. The actual process of using these structures, creating these structures, actually helps us to be better at actually doing the program itself. So it's a worthwhile thing from the beginning, to think a little bit about different theories that might be relevant so that we can make projects that are more likely to work. So when we're thinking about a theory of change, what that theory of change is essentially doing is trying to describe how your program is actually going to achieve change, right? And it's essentially the philosophy of your program. It's a little bit broader. It's a little bit more describing how that psychological shift or how that change in practice is going to occur at a larger scale. So at its base level, most theories of change include two different things. The first is they'll in some way describe the things that you do to achieve a goal. And those are your strategies. And then they'll describe what you're going to get out of it. So those are the results that you expect to get from that. And that's essentially describing the process of change. And if you can describe those things well, people should be able to fairly rapidly understand what you're doing with your program. So these theories of change are actually really important to be able to communicate with others. Someone should be able to look at your theory of change, which is essentially a model that's been laid out, and within a fairly short period of time, 15 seconds, 20 seconds, have a pretty good idea of what your ideas are for how this is actually going to occur, right? And a simpler model is actually usually more valuable because you want this to be something that someone could look at pretty quickly and get the overall picture. Now, this is really important for communication again, because if you're talking to lots of different people, having that there as a centralizing concept for your conversations can be quite helpful. So when we think about change, there's a lot of different scholarship around how changes occur, right? I've talked before about diffusion of innovation theory, and that talks about like what types of interventions work better or worse. We talked about re-aim and the different factors that you think about in terms of elements that make programs be sustainable over time. But there's also different factors that we know about that can influence change that are typically a little bit more personally oriented. So we're thinking about individual change, but this can also be applied to communities or groups as well. So I just want to run through what some of those factors are so you could think about them in the context of a project that you're trying to create. So one would be external or modifying factors, and these are the bigger picture elements around that one is working in. Social factors, environmental factors, people's personal background that they're coming from in their communities, right? So understanding those elements as the background of what your project is taking on is important for thinking carefully through these issues. Another one is thinking about what do people believe the perceived benefits of engaging with this change would be, right? So what do they think, if they're looking at this, what do they think they're going to get out of it? Or what do they think the benefits will be in a larger picture for the healthcare system, for example? You also want to know what people's perceived barriers would be. What do they see as being things that prevent them from actually engaging with this change, for helping out with this project or doing this new thing that you want people to do in clinical practice, right? Understanding those two things can be very important for understanding whether or not a project goes ahead, because the balance between those benefits and barriers is a ratio that sometimes can tip the scales in terms of whether people want to do something or not. Also, if you know about the benefits and barriers, you can know what to emphasize or what types of things you can sort of get around. So a lot of barriers, if you do certain things in your design your program, you can get around those barriers by offering, say, resources or restructuring, the timing of when things occur so that the barriers don't come to being. So those are important elements that we know influence whether things change or not. Another is perceived severity. So if you're talking about a project related to a health-related problem, do people actually think that that health-related problem is a serious problem? Being able to show for a program or project that if you don't do this, that there's some threat there, that there's some problem to not doing this, can be important for convincing people to engage with that change. Now, when it comes to health-related issues, susceptibility is another element to this. So, for example, if we're talking about medical errors, for example, we might think that it would be severe if somebody did do a medical error, but if we don't believe that I would ever actually make a medical error myself, then we have a problem here because people aren't engaging with that. So understanding whether people actually believe that they could do something that is could cause harm in this situation can make a difference. Now, perceived threat or fear can be a motivator for getting people to engage with a program for change. And that's really fear or threat comes from the combination of susceptibility and severity. So if you believe that you're susceptible to something happening, and you also believe that's something that is dangerous if it does happen, then you'll have a sense of threat. If you don't think that it's severe, then you won't be concerned about it. And if you don't think that it could possibly happen to you, then you're not going to be concerned about it either. So you really need those two things, and the combination of them creates a sense of threat. Another element which is really important, and we've known this for a very long time, one of the biggest predictors of whether people engage with a change is self-efficacy, or it's also called perceived behavioral control in some contexts. So this is a belief that you actually can change your behavior. So if you're asking someone to engage with a new nursing practice, for example, and nurses are already overworked, or they feel like it's too complicated and they don't feel like they understand what the actual procedure is, well, they're not going to have a lot of self-efficacy. They're not going to feel like they can actually do it, right? So many interventions, clinical interventions, really do focus on that self-efficacy component, hands-on training or other things to make it so that people feel like they really can do this new approach if they were offered the opportunity to do it. So that's proven to be one of the most important components to change. Response efficacy is another component to this, which is the idea that, okay, let's imagine, say people think that they could do this change. Do they actually believe that by changing their behavior, doing something different, that it will actually make a difference, right? So there's in some circumstances, a sense of learned helplessness, right? If people feel like they try and do different things and nothing changes the system that they're working in, then they're going to have low response efficacy. So sometimes your project is not just to improve self-efficacy, it's also to convince people that if they do these things, they're actually going to get the outcomes that you're hoping to achieve. And then a major factor in a lot of interventions is the social norms within the community that you're in. So what people believe about what other people think about this project or process that you're proposing. This can be incredibly important, and there's a few different strategies you can use to encourage people to think about this in a positive way. So thinking about how to create those norms and shifting those norms. You can also think about champion approaches where you get certain people who are really popular or respected to promote your project. So these are a few different factors to think about in these change sort of processes. So we know that these factors that I've just described are ones that have been shown in many different intervention studies to actually make a difference in terms of people actually engaging with the change. So another thing to think about is how hard it is to change a behavior or change a clinical practice. This is going to vary substantially, but being aware of how hard it is going to help you to be prepared for your outcomes in your intervention. All right. So one thing that makes change relatively easy is when you can switch one behavior for another. So if you're using one type of syringe versus another and you're not really changing anything, right? Otherwise, it's very easy to switch from one type of syringe to another. But if you're changing from one type of syringe to another syringe, but you also have to do lots of calculations and do consultation with a range of different people and things like that, then it becomes a much more complicated process, right? So those types of changes tend to be so the less there is involved in terms of shifting the way that the patterns that people have, the more likely it is that it's going to be easy to get people to do something. Another one is how can you incentivize this? So can you lower the cost? Can you make it increase of availability? Can you make it increase ease of use? Right? So if the change actually makes things easier or has incentives to it, then you're actually more likely to actually have success with or higher levels of success with your intervention. Interventions that tend to be fairly hard are ones that are involved in pretty serious psychological elements, or in some cases addictive elements if you're talking about health behavior change around certain types of health issues. But psychological changes, for example, if you're talking to nurses about changes where you're asking them to change the way that they communicate with patients, the type of feeling that they engage, that they hope to encourage among their patients, and creating a healing attitude or something like that. Well, psychologically, it's actually quite difficult for a person to change the way that they communicate with people, to engage in different types of communication strategies, because we all come from different backgrounds and we have very different communication strategies, and it's actually pretty hard to shift those types of things. Other things that are relatively hard to change are when there's major physical, social, or economic barriers. So those can be quite important. And for things like that, you tend to have more challenge with your interventions. And sometimes interventions are less successful in those cases. Now, that being said, just because success rates are lower for some of those hard interventions doesn't mean that they're not worth doing. Sometimes it's those hard interventions that are actually the most important ones to pursue, right? Because they actually save lives. They make a big difference in these situations. But it's important to think about this gradient between the relatively easy and relatively hard interventions to understand where you're at in terms of what you're proposing with your project. All right, so I'm going to talk about a few different models, and this is just to give you an idea of what sort of theory of change models could look like. Now, I'm going to start off with just some individual change models or community change models. And this is a health belief model, and this is really looking at the likelihood that people will take action and make a change in terms of some sort of behavior or belief, right? So here it's looking at some of the factors I talked about before: benefits and barriers, perceived threat, cues to action, self-efficacy, those different components, and combining them together to describe whether or not someone, in a community or an individual is going to engage with change. So this is just one example of how something like this could be set up. Another is stages of change theory, or the trans-theoretical model. This one was pioneered for smoking, where we look at how people go through changing from not even really thinking about changing to quitting smoking. And they go from pre-contemplation to contemplation, preparation, action, and maintenance, and then ultimately to a sustainable lifestyle. You can also it's also circular in the sense that there could be a relapse and you could go back through that cycle. All right. So this is another model for individual change, but what it does do is for each of those steps, you have different strategies that you use to help people. So you'll use different strategies for getting people to move from pre-contemplation to contemplation, to start thinking about things, then to go from preparation to action, right? There's different things that people need to do. So people who are already quitting smoking, you don't necessarily need to convince them that it's actually important to quit smoking. They already know that, right? What you need to help them to maintain their change in behavior for smoking, okay? So this is another model that is an example of a circular model in terms of behavior change. Another circular model here is just a community change model. And here we're looking at community themes, local health systems, status assessments in communities, forces for change, and then going from visioning to ultimately to implementation. And this is sort of a circular model where everything's related to one another, all right? And there's actually sort of a linear model embedded within it as well. So one thing I'll say about circular theories is there is a challenge when you create circular structures to theories of change. And that is that when you have a do-get model, it becomes a little harder to figure out what the linear thing of going from doing something to getting something is, right? You can still use these circular models because sometimes you want to use them to suggest sort of continual improvement or connections between things. But just be careful about it because sometimes they can be less clear about how you get from point A to point B, right? Which is something that linear models tend to do a little bit better. So here's Swanson's theory of caring and healing. You're probably familiar with this one. Nursing model going from going through these different steps of maintaining belief, knowing, being with, doing, and enabling in order to achieve client well-being. All right. So this is a good example of a linear model. So going from point A to point B, but in each of those steps having distinct actions that you take, right, to think about. Here's an example of a custom-made model. This is a North Carolina Accreditation Learning Collaborative. And this is looking at a mentoring program where you essentially talk about the theory of change here is that you have a nurse mentoring program where you go from creating that to increase nurse job satisfaction, having better job matches, to having nurses trained in population-based services. Because of these two things, you'll get increased public health nurse job retention, and this is public health nurse focused. And then you'll have a stable public health nurse capacity to deliver population-based services. Right? This is a very simple model, but as you can see for this model, if you showed this to somebody, it would take them 15 seconds to understand this is what you're trying to do with this project. Right? Very simple, direct theory of change. This is a more complicated one, right? And this one is looking at family nurse partnerships and describing how changing things related to support, therapeutic relationships, use of tools will lead to program engagement and completion, and ultimately improve self-efficacy and outcomes for mothers. ultimately resulting in improved public services for mothers and children and families. So, this is another example of this type of thing, a little bit more behaviorally oriented, but presenting a fairly clear structure. Just this one will probably take a little bit longer to understand. A very common model that we see used in terms of change models in nursing is the Lewin's change model. You may have seen this before. A lot of students end up using this as their change model. When I've taught this course before, probably half or more of the students ultimately use this model. But the overall idea behind here is that you unfreeze something that a practice that you're trying to change in a clinical setting. And the idea here is that we're doing certain things a certain way, and you adopt certain strategies to try and get people to move away from that strategy, to start thinking about things in a new way. Then we would move to changing, right? So then you want to think a little bit about what are the strategies that you use to actually get people to shift, to move, to transition from what they used to do to something new. And then you move on to refreezing. And the idea here is that you want to, once you've adopted this change, to actually solidify it so that this is now the new normal, basically. So this is a Lewin change model, and here's an example of it being used in preventing nurse burnout. So talking about how you would unfreeze in terms of burnout. So various different strategies there, resulting in a change, and then leading to refreezing ultimately in terms of burnout, right? So to create a situation where people are less likely to have those challenges. So this is just an example of something like this. You can also have educational models. So you can think about creating. This is K through 12 education, but here you're talking about supportive communities, effective schools, strong families, resulting in various different outcomes in terms of graduating high school and other things like that. And this is a fairly clear linear model, and it's essentially that sort of do-get approach where you have a bunch of different things along the way, engaging communities, engaging parents, developing language and literacy, different steps that you do in order to get a result. All right. So you can think about these models in multiple ways depending on what you're trying to achieve. So when you're thinking about creating your own theory of change, you can have a few different choices. You could identify an established theory of change, which perhaps is evidence-based and has been used by a lot of different people, and then adjust it to make it fit your particular needs, right? Or you could also think about developing your own theory that is specific to your project. And here you would figure out what elements you want to include, whether they're more administrative and structural, or whether they're behavior change oriented. It can vary, and sort of integrate that into some form of do to get framing. So we're going to do different things, and we're going to get this outcome. All right. And I would also note you can use different structures for this, but typically the linear models tend to be a little bit more clear for most people in terms of saying, we're going to do these things and we're going to get this, and we're going from point A to point B. All right, so that's basically an outline of creating theories of change. I hope that as you go forward and think about your project, you can think about how you can create this change model so that you can clearly communicate to others what you're trying to do in a very simple, clear fashion, and use that theory of change to sort of structure your assessment and the different elements that you would want to consider in terms of moving forward with your project and assessing that project as well. All right, so thank you very much for listening. I hope that was helpful. So take care, everyone.